All right, I have to leave here around 3:50, so we're going to try to get this finished up today. I got to go to clinical next. So the next thing that I want you guys to understand is somebody asked me a very interesting question, and they were observing something in clinical. And one of the things that we try to manage in the operating room is what's called IE time, okay, which is the inspiratory to expiratory ratio. Okay. The reason this is important is because anesthesia machines that are in the future will never look at really at IE ratios anymore. Okay, they don't anymore, really. Okay? The older machines, because everything was mechanical, had to depend on the ratio to be able to figure out the amount of inspiratory time. IE ratio only matters in the sense that it affects the inspiratory time. Okay? The normal inspiratory time for a human being is 0.5 seconds for air to get into your mouth, down to your bronchioles, and then you spend another about 0.5 to 0.8 seconds in the alveolar phase. Okay? That's what you really want. And the ideal time when you're looking at a mechanical ventilator is around 2 seconds. So that means we spend 0.5 seconds on inspiration for the dead space, and then we spend the other 1.5 seconds of the inspiration for full aeration of the alveoli. Okay? So the actual inspiratory time that we're trying to achieve is actually 2 seconds. Okay? So here's where the confusion. And despite what I tell people, and invariably people are going to come back and misquote me again. I've had that happen more times than enough. If I'm breathing at a breath of 10 breaths per minute, my IE ratio should be 1 to 2. That's what you should have it. Okay? Now, why is that? Okay? Well, here's how the mathematics of it work. Okay? 10 breaths per minute. And I'm going to convert this to seconds. Okay, 1 minute, 60 seconds. Okay, this is going to eliminate the minutes. That's going to give me 10 breaths over 60 seconds, which equals 1 breath every 6 seconds. So what does that mean? That means 1 breath takes up a total time of 6 seconds. Okay, well, what does 1 breath contain? 1 breath contains inspiration and exhalation. Okay, so what I do to teach you this stuff, let me see if I can convert this to blue. Or green, maybe make it work better. No, it doesn't come out any better. 1 to 2. Just imagine that instead of this a semicolon, make this a plus sign. And it gives me 3 units of time. Okay? 3 units of time goes into 6 seconds how many times? 2. Okay? That means for every unit, I'm spending 2 seconds. So in this case, because I'm at 1 to 2, I'm spending 2 seconds of inspiration, and I'm spending 4 seconds on exhalation for a total of 6 seconds. That's why you're at a rate of 10. You're at 1 to 2. Now, if I change that, if I drop my respiratory rate down to 6 breaths per minute, the mathematics of it will basically end up being that I need to reduce my ratio back down to 1 to 4. Okay? And again, how does the math work out? I'll do it one more time so you guys can see it. And then I'll go on to start this topic again. We're going to drop our rate to 6 breaths per minute. Okay? So in this case, we're at 6 breaths per minute. 1 minute, 60 seconds, which is going to give me basically 6 breaths per 60 seconds, which is going to basically get 1 breath every 10 seconds. My ratio that I should be, instead of 1 to 2, I'm actually going to be at 1 to 4. That's where I should be at. Okay, that's going to give me how many units? 5. 5 goes into 10. 2 seconds. So now I'm going to spend 2 seconds of inspiration, but because now I changed this ratio, this is at 4. So 4 times 2 is 8 seconds. And that gives me a total of 10 seconds of time. The only thing I care about is the 2 seconds of inspiration. Now, the reason you may see people change this in the operating room is because of something like this disease process, obstructive disease or restrictive disease, or patients that are morbidly obese. Sometimes you have to expend energy for the ventilator to get the air into you. Okay? Here's how I think of it. Lay down and have somebody sit on top of your chest. Okay? Try to breathe. The first thing you'll notice is your work of breathing goes way up. Okay? If you can breathe at all. Okay? You're going to try. Struggle for air. And you use maximum amount of effort to get the air in. Okay? And that's simply because you're being compressed. You're being restricted in your ability to take in a breath. People that are morbidly obese are difficult to ventilate for the same reason. Now, instead of letting them spontaneously breathe, now you've got to push air through the trachea to inflate the lungs internally. So you spend more time with somebody who has restrictive disease to get the air into them, which means that what do you have to do with your inspiratory time? You increase it. Okay? And that's where you see people playing with the IE time. Okay? If they know what they're doing, they'll change it so the IE time goes up in somebody with bad, let's say, morbidly obese, or somebody who's getting a laparoscopic procedure, and you just have to suffer the consequences of hyperinflation underneath, pushing your lungs up. You've got to spend more time inflating the lung. It takes more time, more energy. So your I time has to increase in those situations. Patients, on the other hand, that are COPDers, that are already largely inflated, giving them more I time doesn't really help. You can actually make them worse. Because if you give too much of an inspiratory time, you begin to overdistend lung areas that already are overdistended. And you'll make the VQ match even worse. Okay? If you hyperinflate the lung, what happens to perfusion to those areas? It goes down. Okay? So the most common cause of hypotension on induction is not the meds. It's the actual hyperventilation that we do. And number one reason that we hyperventilate is not through respiratory rate. Nobody goes in the operating room and puts people at 20 respiratory rates. At least if they do, they're nuts. They don't know what they're doing. Okay? But most of us will not think anything about giving 10, 15 cc's per kilo in tidal volume. But that increases minute ventilation tremendously. And that effect is very negative. It basically depletes volume in the lung, and you don't get a good VQ match. Okay? All right. Most of the time we'll try to 2 seconds. Sometimes we're forced into going below that. And that's why I'm not a real fan of getting in the respiratory rate above 12. Once you get above 12, it's very difficult to maintain an I time of 2 seconds. Okay? And here's what everybody hears in medical school as well as in nursing school. Okay? When people tell you increase minute ventilation to blow off the CO2, how many people have heard that told to them? Okay, so what does that mean to you as a student? Increased respiratory rate, right? That's what it means. But that's wrong. That's the worst thing to do. Okay? What they're trying to tell you is if you see increase in CO2, you increase the effective minute ventilation. That's the wording that's correct. Effective minute ventilation, which means the gas has to get into the alveoli. If it doesn't get in the alveoli, it is ineffective minute ventilation. If you worked in a resident-run ICU, I will tell you that 100% of you that work in the resident-run ICU, when the residents first start their rotation, they will get called by one of you telling them, we got CO2 that's 55. Okay? And instead of the resident getting off their butt off the bed and coming to check on the patient, which is what they're supposed to do, they will say, increase the respiratory rate to 14 and call me with a blood gas in half an hour. Back to sleep he goes. Half an hour later, CO2 is not 55 anymore. It is now 65. So then he tells you, well, increase the respiratory rate to 18. Okay? Call me in half an hour with the next blood gas. Next blood gas goes from 65 to 75. And now the resident begins to going like, what am I doing wrong? I'm increasing minute ventilation. I've doubled it. But why is it that the CO2 keeps climbing? And the answer is, what he's doing is his I time has gone from 2 seconds before, and now he's almost breathing at 20 seconds, 20 breaths per minute, so his I time's down to 1 second. And what is he spending all his ventilation effort in? Dead space. And that's all he's doing is moving dead space air. Great. Okay? And now you got a patient who is severely hypercarbic, acidotic like crazy, and you're behind the 8 ball. Okay? And what they should have done was, that person most likely was main stem intubated. All you had to do was check for breath sounds. You heard that one lung was being ventilated, the other one wasn't. Pull the tube back a little bit, everything clears up and the problem goes away. Or you could have one lung that's got pneumonia and you didn't pick it up. Or the person aspirated even with the tube in place. Or developed a mucus plug. Something else is going on. And that's why we used to teach our residents, stop, get out of bed, and check on the patient. Don't just increase minute ventilation. It was a mandatory order. Anything over 14 breaths per minute, the fellow was called. That was me. Okay? So you found out real quick who didn't know what they were doing and who did. Okay? So this is the kind of stuff that gets you into trouble. And unfortunately, when they teach you this stuff, the people that are teaching you in school are physiologists. I love the guys. They're great. They taught me physiology a lot, but they're not clinicians. And they don't understand that these are machines that we're delivering care with. Okay? And the machines have limitations. And the limitation's time. Inspiratory time is critical to get gas in. The optimum is 1.5 seconds of alveolar time with 0.5 seconds of dead space time. So its overall time is 2 seconds. Yes, you have a question? You got it? Okay. Because we do this all the time. We basically hyperventilate every patient that we put to sleep. We drive their CO2 around 30, okay, or 32, which is in essence going to be a true CO2 around 34 to 35. Okay, the reason we're doing that is we don't want them breathing under anesthesia. We don't want the person to initiate breathing. So we induce a hypocarbic state, so the person doesn't want to breathe. So when at the end of the case, when we want people to spontaneously breathe, we reduce the rate down, so the minute ventilation drops and CO2 begins to accumulate, and then the person wants to breathe. Okay? Yeah. We tend to reduce the rate. If we want people to decrease their overall minute ventilation, we drop the rate down and keep the tidal volumes at the same place. But the IE ratio should fall with it as well, so you can maintain the inspiratory time of 2 seconds. If you don't do that, let's say I left this person at 1 to 2, okay, and I reduced my rate from 10 to 6, okay. Well, what happened to my inspiratory time? 3 goes into 10 how many times? 3.333. Okay, so that gives me an inspiratory time of 3.33 seconds. That's not good. Okay? Now I'm overinflating the lung, and I may actually rupture it. If I'm taking care of a little one, a little kid, I can cause a pneumothorax. Make sense? I time is critical in the sense of inspiratory time. The IE ratio, I don't really care. It's a way of getting to where I want to be, which is 2 seconds of inspiration. There's reasons why I'll go beyond that, 2.5 seconds or 2.8 seconds of inspiration if somebody is very morbidly obese. If I cut anything less than down to 1.5, I'm asking for it. Then I start seeing that my stats begin to fall because I'm inducing atelectasis. Okay? Yes? Yes, if you're asking me if what you're asking me is if I overdistend the alveoli, okay? That would not be on the end tidal CO2. That would be on my pressure over time curve. Okay, the pressure over time curve, what you should see is you should see an inflation pressure, this dead space, which gives you the peak inspiratory pressure. Then when you hit the alveoli, you'll hit a plateau. That's called the alveolar plateau phase. Okay, that's what you should have. It should stay flat. If it rises at the end, that's not good because that means that you're overdistending the lung. At that point, your lung cannot take in any more volume, so it begins to inflect a higher increase in pressure because the lung, what's left, it's going to be injured, is pushing back against you. Okay, and it's causing that deflection. What you would see on your pressure volume curve, you would see what's called the penguin sign. Okay, what it should say is it goes up and then it comes down, and it looks like an extended penguin nose. Basically, pressure goes up without changing volume. So I'm getting a little more technical. I'll show you in clinical how you can say if somebody's overdistended. You can do it transiently to show you. So in a patient, it's not going to harm them. Just go up on a little bit more on the tidal volume until you see it. Then you recognize what you should be looking for not to happen. Now, you will see that change in pressure over time when you're doing laparoscopic procedures. Okay, because that's not that you're overdistending the lung. It's the reason it's happening is because you're getting so much insufflation pressure underneath that it gives you this fake thing that you're overdistending the lungs, but you're not. Okay, so don't worry. If you see that inflection point during laparoscopic procedures, it doesn't mean anything. That's why you set up the ventilator first before you start the laparoscopic component. Okay, because it will fool you into thinking that you're overdistending the lungs. I lost some of you, I know. I lose you, right? You're shaking your head like, oh my God, he's way too technical right now. Okay, well, it will become more technically important when we have this simulator. Hopefully you guys will get to use it, and we'll get you to see what I'm talking about there. Okay? Because some of this, you think it's theory, it's not. It's real practical. It's going to be very much useful to you. The difficult thing for students is that you get so much information from the monitoring that you don't know what you're looking at anymore. You're just overwhelmed with data. To you, it's hieroglyphs. Okay? The beauty of this job is that you begin to interpret everything. Everything you're looking at is giving you information, and you need to interpret it quickly so you can do something with it. Okay? All data is useless unless you have an interpreter. Okay? And you're the interpreter. So while you're here, ask as many questions as you can. I've never met a student that I can't overwhelm, baffle them, do whatever I want. Okay? That's not my point. It's easy to do. You guys have this knowledge base, and I'm here. Okay, what my job is to try to bring my knowledge base here, bring you up. Okay, so one of the things that you'll see, and you can talk to the seniors and juniors, and I work with them, is I keep asking them question, and they go like, Dr. Noel, you asked me that last week. I said, well, you know the answer. Yeah. Okay, let's go to the next level. Okay, and I keep ratcheting it up till they hit the point where they say, I have no clue. Okay. And that's where we stop, and that's where I begin to teach again, okay? So that's where I gauge you. It's not that I'm being a pain in the butt. It's not there I don't get any joy out of watching you squirm, okay? I just want you to tell me, I don't know, okay? When we're there, then this teaching begins, okay? I used to do the same thing with residents. Residents, I would spend 8 hours a day pummeling them all day long, okay? And I was trying to find out where they're at. When they were at a certain level, I kept pushing them, pushing. And that way they get good. That's the way I want you guys to be. I want you to be experts by the time you're finished. because one of these days you'll take care of me or one of my family members. So, all right. So what is COPD, or what is obstructive disease? Okay, it's basically a process of airway obstruction. Okay, and what causes this increase in airway obstruction is due to increases in airway resistance. If you look at the only place where this can really take place, it's in the bronchioles. It doesn't really take place in the trachea most of the time, and doesn't take place in the larynx under normal circumstances. But the area where it takes place and is regulated regularly every day is your bronchioles. You have smooth muscle around the bronchioles, and as a consequence, those smooth muscles can constrict down and cause the resistance to rise. Okay, or cause what's called an obstructive process. What also will affect it is that there's tissue that's around it that's inflammatory in the sense that it can sense inflammation. Okay? So when you get exposed to an anaphylactic or an anaphylactoid-like factor, it will induce bronchoconstriction, okay, which will close down your lungs. If you think about it, it's kind of protective. The reason you have these systems in place is because our environments that we lived in primitive times were not clean. We didn't have air conditioning. Okay? You had your local volcano around here throwing pumice in the air. Okay? And if you were foolish enough to take in big, deep breaths of pumice, you would chop up your lungs and you wouldn't have anything left. Instead, when you get exposed to noxious chemicals, your lungs will close down and try to protect you from taking in deep breaths of this stuff. Okay? The bronchioles do know one thing. As long as I can slow down the toxin and I can deposit it into the mucosa will take care of the junk. It will sweep it up and push it up into my mouth, where I will swallow it, okay, or spit it out. Okay? And you can see that when people come in from fires, you'll see that when they spit, okay, they got black stuff coming out. That's charcoal. That came from their lungs. Okay? And a lot of them will get nauseous and vomit. And some of them will get poisoned from a formaldehyde that's inside the fire. So these toxins can be an issue. Okay? So conditions of the wall, the airway, and peribronchial region are really very important factors. Unfortunately, what happens with chronic obstructive disease is you get hyperplasia. You get an overproduction or too much, the cell size gets too large, and it becomes hyperreactive. And that's what asthma is. COPD is a very ill-defined term. It's basically two disease processes. One's emphysema, which is destruction of the actual elastic matrix around the lung, which it causes overinflation of the lung. Emphysema is a pathological diagnosis, which means that they have to do lung biopsies on you to say that you have emphysema. Instead, we just call you, if you have been smoking for 20 years and your lung, you can't breathe well and you're hyperinflated, we call that COPD. Okay? The other component you could have besides emphysema is you could have bronchitic components, that's a disease of the actual bronchioles, where you get hypersecretion of the mucus glands, and they will literally flood you with mucus. Okay? You'll drown in your own mucus. You will get huge amounts of VQ inequality because some areas will close down, and as a consequence, you get a larger shunt. Here's what emphysema looks like. I'll tell you, the best treatment I had for emphysema was my dad. When we were like 5 years old, my grandfather came down. He was a big Marlboro man. He ended up dying from not cancer, but dying from heart disease because he kept smoking. He wouldn't stop. Anyways, one of the things that I told my dad one day when I was about 5 is, "Dad, I want to smoke." So my brother said the same thing. So I said, "You know what?" My dad brought us 2 cigars and said, "Smoke all you want." So we sat there and smoked the cigars for about 10 minutes. Well, I'd never been sicker than my life. God. So I was puking for about 2 days. And that solved me of ever smoking again. Okay? So it's called negative therapy at that point. But if you don't tell people how dangerous this is, people will chronically smoke and will develop pathological changes to the lung. Now, will everybody develop that? No. Approximately about 1 to 2% of the population has very high alpha-1 trypsin levels, and they don't have any damage from smoking. They could smoke till they're 80, 90 years old and it'd be fine. Okay? Versus some population, around 10% of us, have very low alpha-1 antitrypsin levels, and as a consequence, you get rapid emphysema, rapid bronchitic disease at an early age, okay, in the 40s or 30s. And the rest of us, usually it takes about 20 years, about a pack or 2 packs a day for about 20 years for you to get to significant emphysema, significant COPD. And that includes being around somebody who smokes. So it really, if you are around somebody who smokes, make sure that he's smoking outside, not inside the house, especially not around the kids. Where this is becoming very much a problem is that smoking is activator of asthma. Okay? But emphysema basically causes enlargement of the distal airway spaces and destruction of their walls. Types you see is central acinar emphysema, panacetar, paraseptal, bullous emphysema. Bullous emphysema is the most dangerous for us because it means that there's areas of the lung that are actually bullae, which means that they're big bubbles. And you ventilate these individuals, you can rupture those bubbles, and you can get a very rapid tension pneumothorax in your hands. So it's a little scary to say the least. It's a necrosis of the actual structural protein in the lung called the elastin. As for chronic bronchitis, it's a clinical description. You have to have 3 months of excessive sputum production, okay, usually for 2 consecutive years. So that's a typical clinical diagnosis of chronic bronchitis. When you look down, this is what their mucus looks like. You can see that they're red. They're very hyperemic. That's called, and they also get hypertrophy of the mucus glands in the large bronchi. And what they'll do is they'll get hypersecretions of these mucus glands inside there. Etiology is usually smoking, secondhand smoke, environmental toxins, and could be alpha-1 antitrypsin deficiency, like I said before. That makes the disease occur more rapidly. It's infection and reflux. Now, there's 2 things I want to sort of understand. If you look at the history of smoking, most people didn't die of smoking-related diseases until the 1930s or 20s. Okay, it took about 50 years before that for really smoking became really a disease that caused a lot of cancer. And you got to ask yourself why. Okay? Because in the 1920s and 1930s, a lot of people didn't die of lung cancer. But all of a sudden, after the 1940s, 1950s, there was a huge increase of lung cancer. And the reason that is most likely is because people were smoking cigars before. The American Indian didn't have cigarettes. And they had cigars. They took leaves, tobacco leaves, and wrapped them. Okay? And if you look at a tobacco leaf, when it's properly done, when they actually wrap it, they actually clean the leaves off. And if you have a chance, go to Ybor City one day, which is up in Tampa. Okay? And they actually have a cigar factory. And you actually see the beautifully green leaves and the slightly tan colors. And they use different colored leaves. Okay? But the leaves are cleaned. Okay? And that being said, why does that have to do with cancer? The answer is when you take tobacco leaves for a cigarette, when they come off the fields, they take the tobacco leaves and let them dry in the open. And when they feed it to the factory, the leaves are not cleaned. They're covered in what? Mold. Tons of it. Okay? Then they take your cigarette and crush it. Chop it up. And then they wrap it in this fancy white piece of paper so you can't tell that you're really smoking fungus. Okay? So the reason that you have all these other diseases where you see infection causing COPD is because it's like a fungus. You're smoking fungus. And that's what's killing you. That's what causes the cancer. Okay? Now, in other words, would you get less dose of cancer if you took it and you washed the leaves? Absolutely. Would it be 0? No, because you can't wash the leaves 100%. You can't remove all the fungus. But if you were to remove some of the fungus, it would really help. Okay? And filtering doesn't really help because these are micro molecules that you're talking about. The filters don't really make a difference. Okay? Actually, people that put more filtration, what happens to their cancer rates? It goes up. Of all things. Why do you think they go up? You ever seen somebody with a very heavily filtered cigarette? What do? They suck harder. Okay? They pull more air into them. Okay? And it makes it worse. Okay? So just next time if you think about smoking, think about what all the fungus you're smoking. Okay. The other thing too that happens is if you keep smoking this garbage, it ends up killing you over time. It does it slow, so you don't really pick up on it. Okay. I'd say most of my friends that I went to high school with, about 70% of the males that I went to high school are still smoking to this day. Okay. And they don't have that much disability just yet. Okay. But it's by the time they hit their 50s, all of a sudden that's when you start having problems. Okay. It starts becoming significant after a certain amount of years. Okay. If you were to stop smoking, will it stop your disease? The answer is no. It will just continue to progress and will eventually kill you, but it will take a long enough time that it really won't matter. But you got to stop at around the age of 45. If you stop by the time you have disability, your chance of surviving beyond 10 years is pretty low. Okay, so most people that have significant COPD within 10 years of that being significantly disabled, they're dead. Okay, what's that? If you stop early, then you're basically okay. If you only smoke for about 5 years, it's really not going to cause you a problem unless you have alpha-1 antitrypsin deficiency, which you won't know for another 30, 40 years. Okay? But as long as you stop, the earlier you stop, the safer it is for you. Okay? Like again, I'm just going to tell you how it works. I mean, it's just genetics and it's just luck. I had one lady that was 85 years old, smoking 3 packs a day for 50 years. And she looked at me, Doc, should I stop smoking? My answer to that person is no. Your chest x-ray looks absolutely perfect. Just continue smoking. Have a good time. You're 85 years old. You're going to die of something at that point, okay? She's got alpha antitrypsin levels that are so sky high that nothing happened to her, okay? Now, would I tell that to a 30-year-old? No. Because I don't know their genetic profile. You just don't know. So, but if you have family members that don't have any heart disease at all, and any peripheral vascular disease, and most people that smoke for 20 years, 2 packs a day, will develop severe peripheral vascular disease, atherosclerotic coronary disease, and increase their risk of cancer tremendously. So, women have actually caught up to men in their cancer rates so long. So, because women now are smoking at 2-to-1 ratios in the United States in comparison to men. Okay. Everywhere else in the world, men smoke at 80% or 90% rates. Okay. It's pretty bad. In I think it's Czechoslovakia. It's one of those countries in the Eastern Bloc. They were going to increase the taxes on the tobacco products by about 300%. And they said it was an increase their cost of health care. The tobacco companies came back and told them that you were going to increase healthcare costs by having people stop smoking. And they demonstrated it statistically using the United States as a model of what happens when you have your population stop smoking. No. What happens is instead of dying at 60, where you start giving people services, they're dead by the age of 60. Almost 80%. 85% of your people are dead by the age of 65 from smoking-related diseases. And now you don't have to provide them any more health care costs after that, so it's cost-effective to keep everybody smoking. And it was so cynical, guess what they did? They didn't change the taxes. They left them alone. It was interesting, but, I don't know. I think the older generation has something to give to the younger population in the sense of you lose them too early in life. They can't teach people some of the basics, what you should and shouldn't do in life. But anyway, COPD is one of those kind of things that you can either have 2 types, type A or type B. Type A are the pink puffers. These are the emphysematous patients. They get this really kind of rachitic chest. You can see this is a picture of one. And they look like this. They're extremely debilitated. You see their arms begin to waste. The reason they're doing that is their workload is so high for work of breathing that they're beginning to waste protein. Okay, they get marked chest overexpansion. They don't really get any cyanosis, but they have very quiet breathing sounds. Their jugular venous pressures are normal because they don't have any pulmonary hypertension, and they really don't develop pulmonary edema. Their PO2 is slightly depressed, but not that significant, and their CO2 tends to be normal. The other ones are, this is what you tend to see. In these people, you see more of a dead space issue. It's not really a shunt. In the blue bloaters, which is what you see, these people tend to be more overweight. Okay, this is more the bronchitic components, which is B with blue, with bronchitis. You get increased dyspnea over years. You get frequent cough. They get early cyanosis, and they drop their PaO2s. They're often very low, and their CO2s are elevated. So these people are chronically hypercarbic and hypoxemic. They also have development of pulmonary hypertension, which increases their JVD, which is jugular venous pressures. You'll see that they have much more degrees of shunt. See, so this is the disease process now. It's shifted from dead space now being mostly due to shunt. Pulmonary function tests in all COPDers, you have reduction in FEV1 to FVC ratio. Your COPD is also values that are increased as total lung capacity. Your FRC, residual volume are all increased, as well as airway resistance. You also see a reduction not only in FEV1 ratio, but also your because of the resistance increase, you'll see a decrease in forced expiratory flow of 25 to 75. Your Vmax is 50% is reduced, and as well as your 75%. And you have a reduced forced vital capacity as well. So what you're seeing in these individuals is the emphysematous portion, or the bronchitic component. Both are showing signs in the red and blue, which is on this end. This is what you see in a flow volume loop in these individuals. Okay? So their FEV1 to FVC ratio is significantly diminished. Gas exchange is you see a VQ mismatch, low PaO2s with or without CO2 retention, depending on which part of the gamut they're in. If they're in between A's and B's, you'll see some CO2 retention, but it's really the B's that get more of the CO2 retention. If you see over time, as you get damage to the capillaries, especially for bloaters, you get HPV, which is hypoxic pulmonary vasoconstrictors, activated due to hypoxemia, and you have increase in pulmonary vascular resistance and increase in PA pressures. Eventually, it causes the right ventricular load, which causes right ventricular failure, and you develop what's called cor pulmonale. Polycythemia is also a big problem with these patients because of the severe hypoxemia they develop, and that increases viscosity, increases the risk of thromboembolism, and all sorts of other problems. The other thing that you got to watch for is control of ventilation. Is some of these people become O2 dependent, okay, especially the blue bloaters. Sometimes BiPAP or CPAP can be used to help maintain these people from going into severe hypercarbia and hypoxemia in the middle of the night. But really their central chemoreceptors or CO2 response is significantly diminished, and the peripheral carotid chemoreceptors become the primary agents of breathing. So if you give these people too much oxygen, you can induce them to stop breathing. Okay? In changes in early disease, you see an increase or decrease in the amount of sputum produced. You also see an increase in thickness of stickiness of the sputum. This is for the blue bloaters. The change in the sputum color from yellow to green is not good because it's an indication of infection. Increase in severity of shortness of breath, cough, and wheezing. If you see the sputum turning green, what's the most likely diagnosis? What's the cause? Pseudomonas aeruginosa. Okay, Pseudomonas will actually has a nice bright green color when you culture it out. Okay, these people don't feel well. Of course, you can get right heart failure, which causes ankle swelling because of the low PaO2 values. These people have increased levels of confusion, slurring of speech. They tend to put themselves in a lot more pillows and sleep in chairs, and you see an unexplained increase or decrease in weight. Usually, the decrease in weight is in the emphysematous diseases, and versus the bronchitics tend to gain weight. The reason they're gaining weight is because their activity goes off. They won't move around. Okay, so they stay sedentary and they eat more. Increased morning headaches, dizzy spells, and restlessness indicates hypercarbia and hypoxemia. Yes.